1, we are live now. You may start.
Very good evening, one and all. First of all, on behalf of Intas Pharmaceuticals and the Altis division of Intas, I, Dr. Sandesh Vadodkar, very warmly welcome you all for today's edition of Smile Podcast, which is an academic initiative which is brought to you by Altis division of Intas Pharmaceuticals. It reflects our shared commitment to advancing the continued medical education in the management of complex dental cases. At Altis, the proud makers of trusted pain management brands like Hyphenac, Hyphenac P, and Hyphenac SP, we are dedicated to supporting the ongoing medical education that ultimately leads to improved patient outcomes. Let me just give a brief about Intas Pharmaceuticals. Intas is one of the leading global pharmaceutical companies with a presence in over 85 countries. It has achieved key R&D milestones that includes the development of endoxifen, which is India's first NCE for the management of bipolar disorder, and the launch of patented Aqualip technology-based drug delivery systems. Intas was also one of the first companies to have launched biosimilars in European Union and is consistently ranked amongst the fastest growing corporates in Indian pharma market. Intas has global manufacturing, packaging, and R&D footprints spanning across 16 sites, including 5 in Europe and 6 with European GMP approvals. Facilities are located across India, UK, Greece, and Mexico, supporting a wide range of products. And over 4,000 manufacturing staff supports the operations that meet the international regulatory standards, including those from FDA, MHRA, and EMA. I feel proud to share that Intas was the first company to launch the generic brand of aceclofenac in India. Hyphenac, it is the name I'm sure many of your patients have benefited from over the years, making it a trusted choice in pain relief. Hyphenac comes in different SKUs, Hyphenac, Hyphenac P, Hyphenac SP. And
Hyphenac SP. Superior power consists of serratiopeptidase, 15 milligrams enteric-coated granules, paracetamol 325 milligrams, and aceclofenac 100 milligrams. Serratiopeptidase can be degraded in stomach acid, and effectiveness can be reduced if not protected. Serratiopeptidase in Hyphenac SP is available in enteric-coated granule form. Enteric coating prevents degradation from stomach acid and ensures intact entry into intestine. It leads to targeted delivery at intestine, where it is best absorbed. It maximizes bioavailability of serratiopeptidase and patient outcomes. Thus, enteric-coated serratiopeptidase ensures multiple benefits. Protect serratiopeptidase and enhance its absorption. Deliver serratiopeptidase to intestine to ensure targeted delivery. Increase bioavailability by increasing absorption. With increasing bioavailability, improve patient outcomes.
Hyphenac SP is the preferred triple combination brand that is being preferred in the management of various complex dental cases for pain management.
Hyphenac SP.
Orthodontic treatments have evolved remarkably over the years, from traditional braces to growing popularity of clear aligners. While both the modalities are highly effective, achieving optimal outcomes depends not just on the tools that we use, but also how well we understand the principles behind them. So today's session, all about braces and clear aligners, the do's and don'ts, aims to bridge the knowledge gaps, clarify misconceptions, and provide practical guidance that can enhance our clinical decision making. So with this, I would like to welcome the speaker for our today's podcast. First, the moderator, Dr. Naisargi Mehta. Dr. Naisargi is orthodontist and certified Invisalign specialist, practicing at braces and faces and other consulting clinics. She is passionate about transforming lives through personalized and holistic orthodontic care. She blends aesthetics with modern innovation to offer comfortable and discreet treatment options using Invisalign. Dr. Mehta is experienced in a wide range of orthodontic techniques, emphasizing long-term health and functional benefits over just aesthetics. And I welcome Dr. Naisargi. And
Thank
I
you.
also like to welcome the speaker for our today's podcast, Dr. Aanchal Shah. Dr. Aanchal is uh, a prosthodontist and oral implantologist with BDS, MDS, and fellowship in maxillofacial rehabilitation. She was ranked 66 in AIMS, PG, and NEET MDS with academic awards at national and state conventions. She has published many papers. She has published in IJDSIR with multiple in vitro studies on bite force, color stability, and pulpal temperature. She has special interest in dental rehabilitation of oral cancer patients with a holistic approach to maxillofacial prosthodontics. She is actively involved in community camps and dental outreach initiatives. With this, I would like to hand over the session to ma'am. So it's over to you now.
Thank you so much, Dr. Sandesh. Thank you so much, Intas, for this wonderful introduction. Thank you for this wonderful opportunity that you gave us so that we can discuss about a very important topic these days, which is braces and Invisalign, and why and when is it necessary, for which category of patients we do what type of treatment. I think that clarity is very important when it comes to clinical dentistry. We all are aware about the theoretical aspect, but when it comes to practicality, somewhere down the line, we need a practical orientation about all of these cases. So, Dr. Naisargi Mehta, who is a certified Invisalign expert, she will help us dive deep into this world of orthodontics. And me being a prosthodontist, I'll be able to help you out with some concepts about occlusion that can sound confusing to so many people these days, even though they might be practicing dentistry forever now. So without much ado, I would like to share my screen. I would like to share the presentation so that everyone can benefit from this. I hope everyone can see the screen now.
Yes.
Okay. So here it is. I think everyone has introduced Dr. Naisargi Mehta. She's a certified Invisalign expert, and she's running a clinic, braces and faces, and is a consultant orthodontist at so many clinics in Ahmedabad. And this is me, Dr. Aanchal, for you. And I practice at Dr. Shah's Smile Studio again in Ahmedabad itself. So we are here to discuss something about aligners, braces, and everything about perfect occlusion. But without knowing much about occlusion, we cannot discuss directly aligners and braces. So that's why I would like to ask Dr. Naisargi now, help us all understand all types of malocclusions and how they exist in patients.
Yes. Hi, everybody. This is Dr. Naisargi. So I'll give you a quick brief. I think that everybody is accustomed about the dental malocclusions. We know overjet, we know crossbite, we know open bite. These are all very basic problems that we have come across in our daily practice, and we see in almost say out of 5 patients, we see it in about 4 patients. But what aspects do you need to see when you're looking at a patient when the patient has come in to you to ask about orthodontic treatments, and your orthodontist will take their own sweet time to come in for a consultation? So what are the basic aspects that you need to look at? So it is not just dental. Apart from dental, you also need to look at the face, the skeletal structure. That is something that is very important, and most of the time we tend to miss out on that. So, Dr. Aanchal, could you just change into the next slide? Yes. So, more often than not, when you have some kind of dental malocclusion, there's also a skeletal malocclusion underlying. For example, if you look at, you all know about the class 1, class 2, and class 3, but dental class 1, class 2, and class 3 is one thing. It is, you also need to see if the malocclusion is presenting in the jaws as well. So, if the lower jaw is positioned slightly backwards, then it is considered class 2. Whereas if the lower jaw is positioned forward, then it is considered class 3. Now, the teeth may be in crossbite. Sometimes this happens that the teeth are in crossbite, the anterior teeth are in crossbite, and it seems like your setting is in the class 3 setting, but the jaws are perfectly fine. So these are things that you need to take into consideration when you are giving a primary consultation to the patient regarding orthodontic treatments. This is, of course, class 1, class 2, and class 3. Other than this, there are also some other skeletal conditions that the patient present with. Depends a lot on the lifestyle. Like if you talk about a patient who has a narrow arch, that generally presents in patients who have had a long-standing thumb-sucking habit, or they've had bottle feeding for a longer period of time. So those patients generally present with a constricted arch. Now, of course, correcting them is also based on the on what age they have presented. But then, yes, these are the things that you need to see. That if there's a narrow arch, if it is a broader arch, or whatever, so these are the things we need to see. Other than that, there's also sometimes a deviated chin or some other those kind of malocclusions that we need to take into consideration. Now,
So now coming to this, we have understood occlusion. We know that they're basically they're class 1, class 2, class 3, and not just dental. We have to look also to the skeletal aspect. So taking away from this, now if we want to correct this, so what are the various techniques that you would recommend which are followed, and for which patients which techniques apply?
so, of course, we all know there's braces and there's aligners, but what are the options available in braces also? Because these days there's so much happening in the world of medicine. There's newer techniques coming in every single day. So you all know about the regular conventional braces. Other than that, there's self-ligating braces. Everybody has heard of them. These are basically copper nickel titanium wires that are used, and the brackets have a door which basically holds the wire. So these are way more comfortable for the patient in terms of, because there's copper, so it works using the body heat of the patient. So there's less pain compared to your conventional traditional braces. There's no elastic around the brace, the bracket, right? So then there's less friction happening, because instead of three things interacting together, the wire attached to the bracket and an additional wire attached to it, there's just two things. There's just the wire and the bracket. So there's less friction. So we have better control because we don't need to take the friction aspect into consideration when we are doing the treatment. So the treatment becomes faster and pain-free. And of course, both these types of braces come in ceramic variations as well.
And then
Yes. Now, clear aligners, everybody these days has been talking about it, and everybody has questions regarding aligners. Aligners have a very different mechanism. If you look at braces, the mechanism behind the braces and mechanism behind the aligners is very different. They're completely opposite, if I may say. So aligners basically hold all your teeth together. It works, depends a lot on software. We have the pre-treatment, we know what the stage, at what stage the patient is right now, and we plan an outcome for the patient using software to the point we need to take it. Now, from starting point to the ending point, trays are planned that, okay, we need to take it from here to here, so this much movement needs to happen. So these many number of trays are required, and that is how they generally work. Why they are better than your braces? So I wouldn't say they are better technically in terms of, if you look at outcome, treatment outcome is pretty much the same. Of course, it also depends on what lab you're using to get manufacture your aligners, because a lot of it kind of jots down to that. Because if the lab is not able to take into consideration the doctor's instructions, the aligners are going to pretty much not do their job, right? So, Dr. Achal, could you take it to the next slide?
just doing that.
Okay, in the meantime, let me just tell you why they are beneficial in terms of comfort. It is basically better in terms of comfort because firstly, with braces, the patient has restrictions in having their meals. They're asked to stop eating any kind of hard substances, any kind of sticky substances, of course. So that is not a concern here because the aligners are going to come out and they're going to pop back in. So that is that. Other than that, in teenage patients, mostly because they are into sports, so they have a tendency to, that sometimes they are in that, they're playing and then the ball hits their face and there's a lot of bleeding that happens because of the cuts of the braces. So that way, aligners are better. Also, a very important aspect that we need to take into consideration is the lifestyle of the patient. The patient are sometimes traveling. So for those kind of patients, aligners are a very good option because you don't need to call the patient in very frequently. So with braces, you need to call the patient every month. With aligners, we may or may not even need to, sometimes we may not even need to call the patient during the treatment because we can track the patient virtually using video consultations or the applications that these days the aligners come with.
Very true. Now, for a child who is in mixed dentition stage, which is, let's say, age between 6 to 12 years. So how often should a child visit for consultation, and how often should the consultation be planned, and what is the reason for that?
Yeah, no, this is a very good question. And this is for all the dentists out there, that if you have a patient coming in at, say, 8 years, we generally tend to tell the patient, you need to wait it out, let all the permanent teeth erupt, then we can plan an orthodontic treatment for your child. That is not the case because more often than not, sometimes the problem lies in just one or two teeth. So if that gets corrected, automatically all the other teeth start erupting into the correct position. So if that is happening, we can stop that while the teeth are erupting. So I generally ask my patients to get their first consultation when their first milk tooth has fallen off. Once the first milk tooth has fallen off, we can see where the permanent tooth is erupting. If it is erupting properly, it's a good thing. If it is not, we can treat just that one particular tooth and it will automatically solve all the other problems. I have a patient listed here. Can you just show the next slide?
This is for myofunctional, but yeah, this
Yes.
is the one.
So this is a boy who had come to me at 7 years of age. You can very clearly see that the boy has a crossbite in just one single tooth. So the upper central is in crossbite with the lower central. Since the tooth was erupting, it was not fully erupted. The upper central, you can see it is partially erupted right now. Since it was partially erupted, we gave the boy a Catalan's appliance. You've all probably heard of it sometime or other. It is called a Catalan's appliance. It was given, and within a month, if you look at the third picture, the crossbite has corrected itself. So now in this boy, you are seeing spaces, of course, but we all know ugly duckling. So once the canines erupt, the spaces will close up on their own, and the boy will have a perfect smile. Right? This is just in 1 month. The boy did not have to go through all the other procedures, the braces stick into his teeth and regular consultations, regular appointments, this, that, nothing. We just gave him one appliance, corrected the whole thing, and now he's living free.
So these are the wonders that happen if we go for early intervention. That is if your child is, let's say, 6 years. And
other than that, also so many other functional appliances. We need to give habit breaking because in some cases, the malocclusion is just because of the habit, right?
Yeah.
So many patients must have come into your clinic and everybody else was joined in that the parents would be probably complaining, hey, but the child breathes through his mouth instead of the nose. So every time the child is sleeping, his mouth is probably open, right? So that has a lot. Most of the times it is because of the position of the lower jaw. So when the lower jaw is positioned backward, it kind of obstructs the airway.
The airway, yeah.
So because of that, now because the child keeps his or her mouth open, it kind of proclines his upper anteriors as well. So we think that because of the proclination, his mouth is open, but it is the other way around. Sometimes because of this problem, because of the lower jaw positioned backwardly, that there's a problem in the upper jaw as well. So if we correct this whole thing while the child is still growing, because these days, you all know that in our books, we were taught that the primary growth gets completed at the age of 12 to 13 in girls and 14 to 15 in boys. But these days, it is happening much sooner in girls. The primary growth gets completed by the age of, say, 11, 12, 11, 11 and a half, 12 is maximum. And boys are done with their primary growth in about 13 years or so. So if you wait for all the permanent teeth to erupt, you lose out on the primary growth because the canines will come in, say, at the age of 13, the canines premolars will come in. So you lose on the growth. And then you'll have to go through a longer and more painful treatment. It will be a struggle for you as well as for the patient. So it is much better that, we address these things while the child is growing and we can, stop major problems happening later.
And sometimes what happens is if we assess the patient every 6 months, what we come to know is we come to know certain habits that are developing and we can stop it right there. And if we don't allow these habits to develop, like thumb sucking, nail biting, tongue thrusting, if we don't allow child to develop these things, then everything comes under preventable category. And ultimately the occlusion is better, and you might not need any ortho treatment, or you might need only somewhat.
Yeah,
that's what I would like to ponder upon. I think we missed out on one point, which is adjuvant myofunctional appliance.
Yeah, so these are all appliances that you've heard of. This is what you need to take into consideration when you're consulting the patient, that if the patient has a skeletal deficiency that needs to get corrected, apart from the braces, we may need to use these appliances as well. So you need to inform the patient accordingly that the child has these issues, and we just don't just need to correct the dental aspect, we also need to correct the skeletal aspect, where we'll need to use these kind of appliances. There's a twin block that you've all seen. There's an arch expander. Now this is advancing on your right. The rightmost appliance is the advancing. Earlier we used to use forceps appliance. You may have heard of it, Jasper jumper and forceps, but those were very bulky and visible on the face.
Yeah.
This is a small appliance just attached from upper molar to the lower molar. So obviously, with the as evolution is happening in the field, things are getting much more comfortable now.
Yeah. So now, can such cases be managed with clear aligners? If the cases are like, as we mentioned, skeletal malocclusion, not just dental, can such cases be managed with clear aligners, and when?
Yes. So a good question again, that these days patients don't want to go for braces. Everybody is looking to go for aligners. Obviously, as I said earlier as well, that it depends a lot on what lab you're referring the case to, because not all labs are not, they're still not that well developed that they could undertake such cases. But then, yes, there are certain labs that have done their research really well, and they are very well able to incorporate our instructions into their mechanics. So this is basically a case of Invisalign. And you can see there's a class 3 elastic that we have attached. Other than elastics are, of course, a very good alternative. But while the child is still growing, we don't need elastics. Elastics are just for dental correction. They don't give you any kind of skeletal correction. There's more for skeletal correction. Could you change to the next slide, Dr. Anchal? Yeah. Yes. So what you can see here is basically an arch expander. So aligners are anyway supposed to be changed every week. Now, earlier for expansion, we used to use that Hyrax with the key that the parents had to put in the mouth of the child and rotate every time according to the plan given to them. But now these basically, they come in a proper set, and the child can change them every single day, or alternatively, whenever according to the plan, right? So now these things are here. There's this, and if you look at the right side, that is basically the aligner has wings that work like twin block. So they'll lock the mandible in a forward position. So of course, these things are there now in aligners that are giving very good outcomes. We have done those cases, and there's very good outcome that you'll be seeing in these cases. So the concern that you have that aligners are not very good at say doing certain kind of cases, that is not true. Although yes, there are some patients where we recommend the patient not to go for aligners. Could be anything, could be their lifestyle, could be some malocclusion that we think that, because aligners, you're planning the whole thing beforehand. With braces, you have control. The patient is coming in every month, and you're planning every single month according to their progress. So those cases are very rare now. In most cases, you will be able to treat patients with aligners.
Yeah, very true. So now, what are the factors that you consider before choosing any of these modality for your patients?
Yeah, so this is what I was just talking about, that there are certain things that you need to take into consideration before suggesting a certain category of treatment to the patient. So there's three things that I generally take into consideration. First is malocclusion. As I told you, there's not just dental, there's skeletal as well. So you need to take that into consideration, whether you just need to give them a dental correction or you also need to include a skeletal correction. One is that. The other is age-based, that if the child is growing, if the child is still into that phase where we can break a habit, or if the child is into a phase where we can give an interceptive treatment to the child, so you will give appliances accordingly. Whereas if the child, if it is an adult, if they've grown complete, the primary growth is complete, then you will take those things into considerations. You also need to sometimes take a surgical intervention into account, because if the growth has completed and there's a skeletal discrepancy which is major, which you cannot just camouflage, because sometimes we do plan camouflage treatments as well. Most patients are not willing to go for a surgical intervention. So in those cases, we can plan a camouflage, but that is very specific to each patient, because not all cases can do well with camouflage treatment. So you have to take surgical intervention into consideration. You've all heard of distraction, osteogenesis, all those things. So there's a chart here. The child you can also, when you have a child coming in after 3 years and you come to know that the child has, say, nursing bottle caries. The child has come to you with multiple caries, there's nursing bottle, you can very clearly see. So you need to instruct the parents that if the child is still on bottle feeding, they need to stop that. And you need to see any signs of growing discrepancies. Although at this age, it won't be visible much. But then if it is not stopped, the habit is not stopped at that point of time, it may develop into one. Okay, so at 3 to 6 years also, you can give a consultation to the patient. At 6 to 9 years, as I said, all these myofunctional and interceptive treatments can be done. If you're extracting a tooth in a child, space maintainers are a must, because if the space closes up, the erupting permanent tooth will not have enough space, and then it will lead to malocclusion throughout the arch. Then, of course, 9 to 12 is our favorite phase. 9 to 12, we do everything that we want to do. It gives you great outcome, because the growth spurt is full blown, and everything that you're doing is giving very quick results. So again, 9 years, most doctors tend to send the patient back that you can come in at around 11, 12 years of age. But no, particularly if we talk about Invisalign, Invisalign is doing a great job for mixed dentition patients. They've come with Invisalign first, where they are giving compensation, eruption compensation, that they take the size of the tooth into account, that the tooth which is supposed to fall off and the permanent tooth which is supposed to erupt. They give space for that permanent tooth, despite aligners being manufactured according to the tooth, according to the vacuum pressed on the current situation. They give you space for that. So that is a very good thing, because these cases are something that you cannot do with even braces, because you need to continue the braces till all the teeth have erupted. But then with Invisalign, that is also again a very good thing that they have come up with, and kudos to them.
Yeah.
Yeah.
A truly game changer.
Yeah.
So,
And the third, as I said, I took three aspects into consideration. The third is lifestyle. So if the patient is a frequent traveler, or say the patient is NRI, they don't live here in India, but they've come for a consultation. So in those cases, you generally prefer giving the patient aligners, because braces, they'll need to come in every month. So it will be a problem for them. A food lover, of course, because with braces, there's restrictions. So food lovers generally tend to go for aligners that they can remove, and they can. Also, one thing you need to take into consideration, if you need to see if the patient is motivated from themselves or somebody else forcing them to do this. Because the patient is self-motivated, no, they will wear the aligners properly. This is a big problem with aligners, that patients sometimes, uh, when it starts paining, they may probably remove it and then they would forget to put it back in. So of course there is application on their phones, but we all have those applications, water reminder applications and this and that. We don't generally drink water according to the application reminder. So you need to also motivate the patient that if you feel that the patient will follow the proper timeline, only then you should pitch aligners to the patient. Otherwise, give them braces, because it'll all come down to your control, right? Sports person, as I said, may cause injury. The braces may cause injury. And speech considerations. Now, aligners are generally covering the lingual surface of your teeth. Okay, so once the patient has started using aligners, it may take a while for the patient to get used to a different surface feeling on their tongue. Okay, so you need to take that into consideration. Although it will go away within a week, at max a week it will take, the patient will get used to it and they'll start speaking normally. Then yes, you need to inform the patient that these things may happen if you're going for aligners. With braces, the lingual surface stays free. So yeah, these are the things you need to take care before suggesting a particular treatment modality.
So if ignored, then what are the possible consequences of malocclusion?
Yes. Now, this you need to tell your patients this. This is what it comes down to. That if the patient has their questions about getting orthodontic corrections done, because most people relate orthodontic correction to aesthetics, but it is so much more. Aesthetics is a very tertiary part, I would say. Primary is functionality and stability. So we need to first take that into consideration. Only then we take aesthetics into the scenario. So you all know that brushing is a problem. If there's malocclusion, there's spaces that are covered and your brush is not reaching all those spaces. That everybody knows. But other than that, what are more grave consequences? I'll show you that. This is a patient that had come with a crossbite, posterior crossbite. If you can see, this is a heat map basically. If you look at the left side, the upper teeth, you'll see there's red spots on the molars. So those red spots show an intensified bite force in that particular area. Whereas if you look at the right side,
Yeah.
if you look at the right side, it is absolutely blank. So there's no force on the right side, whereas all the force has accumulated on the left side. So this patient will then end up with a nice TMJ problem later in life.
So to simplify it, Dr. Naisargi, TMJ, we might have to explain them. It is
Yes.
a joint between upper and lower jaw.
Yeah.
And that continuously functions while we chew. So if our bite is not okay, we might put force only along one side or maybe on some teeth only, like only canine, only premolar. And because of that, what happens, the force relays to the joint, and on one side patient will complain of severe pain, and you won't be able to understand why that pain is there until and unless you go through analysis like this. So that is something about TMJ.
Yes. That is very well said. Of course, TMJ, as Dr. Achal said, the joint. So if there's not proper distribution, it will relay to the joint. And that will be a problem for you later.
Yeah.
Yes. Then Dr. Achal will have to come in.
Yeah, patient will have
Yes.
to be referred to me after that.
Yes.
Because joint problems are something which are not entirely reversible, but we have to manage it. Unfortunately, most of the patients at a young age, they ignore malocclusion. They're like, aage ke daant achhe lag rahe hain na? So why to go
Exactly.
for orthodontic?
Exactly. So, as I said, the class 1, class 2, and class 3, if there's a dental class 2 or class 3, the teeth are not well settled at the back. Now, the front teeth may be perfectly aligned or
Yeah.
would be well, but then just the back teeth are not properly settled. So, then that is when this scenario happens. The scan that I showed, that happens in those cases.
Yeah.
Other than that, sometimes the jaw is aligned, but as I said, So this is very specific to, I would say it is more prevalent here in the Western zone, the Gujarat and Maharashtra crowd. They have this tendency. So as we all know, malocclusions are also genetically influenced. So they have this tendency where the lower jaw is positioned backwards.
At back.
So in those scenarios, as I said, the airway is also obstructed. So that also needs to get, it may, further get more complicated and may lead to sleep apnea and such other things. So that is also that we need to take into consideration. Posture is something that people don't realize, that your jaw alignment is going to decide your posture as well. Not just your posture, also people who have a complaint of, neck pain. Most people, they say, "Arey, neck pain hai." So all those things also have a lot to do with your jaw relation. More often than not, if your jaw relation is corrected, you need to also see your frenal attachment, your lingual frenal attachment. So in those, sometimes that is also what is causing a certain malocclusion, because the tongue is not able to give the right developing forces to the jaws, and that is when malocclusions may develop. So these are things that you need to address very early on, so that these things can be corrected and the growth can happen at the correct the right amount, right?
Very well said.
Yeah.
And yes, these are the TMJ issues and the spine
Yeah.
issues that we were talking about. So jaw functioning is basically not just chewing and looking good. It's also the whole structure of muscles, the whole functioning of your posture, your muscles, everything should be taken into account, and then you can decide what treatment is right for my patient. Patient will complain of jaw pain, but the etiology will be your teeth. So at times even ENT people refer to dentists that there is something in the jaw. You decide, because patient will complain of pain near ear. Even ENT people will refer you cases and they will say that there's something in the jaw. Please figure out. You are dentist, you can tell me. So you should be able to look at these things, the malocclusion and the other problems that patient might be having.
Dr. Achal, I would also like you to elaborate, because even after we've corrected the occlusion, we've corrected the malocclusion, I would say, patient still has, because the TMJ still takes time to, again come back. So I would like you to elaborate how you tackle those kind of, because, okay, we have corrected the malocclusion, but now what? The TMJ still needs to settle. So I would like you to tell me that.
In most of the cases, what I do is I first figure out patient's correct centric relation. As dentist, everyone knows what is correct centric relation, but no one knows how to do that when patient comes to the clinic. We have read in our textbooks about centric relation, but we need to first identify correct centric. For that, you need to relieve bite of the patient. What happens is, if for a long time patient is under force, so your lateral pterygoid muscle that gets contracted. Now to release that contraction, you need to give something called as anterior deprogrammer. Anterior deprogrammer can give result varying from 1 hour to 24 hours. Depending on the severity of the spasm that patient has of the lateral pterygoid, you can give that anterior deprogrammer. Once the muscles are relaxed, then you can do bimanual palpation like shown by Dawson in Dawson's textbook. You can then do bimanual palpation, and then you can identify correct centric relation. Once that is identified, then you can deliver something called as heart splint. Everyone is giving night guard for jaw pain, and that is again a big malpractice, because that will worsen your condition. Giving night guard will only stop patient from bruxing, but it will not correct what has already happened. It will not correct your lateral pterygoid spasm. So that practice is should be obsolete now, because heart splints should be fabricated in a correct way. Once patient's lateral pterygoid contraction that gets released, then only you'll be able to figure out correct centric, and then you can figure out which tooth is interfering and is what point there is interference, because at times there are small restorations which are interfering. So you need to just correct that, and patient can be free. Patient can be free from severe TMJ pain that does not allow them to sleep at times. So this is ideally, this is the protocol that I follow at my practice, being a prosthodontist. But there can be different protocols as mentioned in Dawson, but this is what I would like to go about when it comes to correcting them. So this is bimanual palpation using anterior deprogrammer. I think if it shows clear picture of it. And this is the kind of heart spin that I usually make on semi-adjustable articulator, where there is dots at the back and lines at the front, so that proper jaw positioning takes place.
Yes. So coming to ortho-restorative cases, now this is where you'll need a team. It is a multi-specialty approach. So now, particularly in the older patients, what happens is that because of malocclusion, there's also other problems that have started happening in the teeth. They may have caries primarily, yes. Other than that, they may have sometimes even lost a few of their teeth. Okay. So now this is a case that that was at my clinic, and Dr. Achal has helped me with this. This patient had come to me with, of course, midline diastema. You can see there's a crossbite in the lateral as well, but she had implants in her lower molars. So and you can see there's very little overjet that I could use to retract her upper incisors, and lowers could not be retracted because of the implants. So you always need to take this into consideration, that patient who has implants in their mouth, particularly in that area, you cannot apply any kind of orthodontic force. Otherwise, it will hinder with the implant healing and the implant may become loose. So what we did was we closed the diastema. Dr. Achal, can you move to the next slide? Yes. So we closed the diastema and we created, and you can see the laterals are relatively smaller than they're supposed to. So we closed the diastema and we created space for veneers, because anyway the laterals were smaller. The diastema had to be closed. That was closed, and the space was evenly distributed around both the laterals. Of course, we had taken Dr. Achal's consultation for this, that is the space enough or not. And then according to her guidance, the space was kept. And then, of course, the veneers were planned. We have a video of the whole thing. Without shaving off any natural tooth structure, we could give her this beautiful smile.
Yeah.
And she's a 44-year-old patient. She's turned 45. By the time we gave her veneer, she turned 45. So if anyone comes and asks you, okay, 44 years old, I think I'm 44, I think it's too late for me to get braces, you can show them this. This is what she ended up looking like.
Yeah.
I would also like to point out that in older patients, you need to take the bone density into consideration as well, particularly women, because around menopause, there's a lot of hormonal changes happening in the body, and those things need to be taken into consideration. That is a very important aspect that will decide not just your mode of treatment, but it will also decide the duration of the treatment and what kind of forces can be delivered and not. Right?
Yeah, this is a small video.
Yeah, now this is a case, this is a very interesting case. You can see there's this is a 13-year-old boy and he has already lost a molar. We do not want to replace that space with an artificial tooth. The boy had a developing third molar tooth bud. This is using aligners. You can see the second molar has been pulled into space. Now, this is just phase one. The patient is still undergoing treatment. He's on his 23rd set, I think, right now. And it has been tracking brilliantly. And the second molar is currently moving into that extraction space. We have created space for the third molar. So whenever later in life the third molar erupts, there'll be ample space for the molar to come in, and that will replace the second molar. So again, contrary to the popular belief that aligners are not able to give good outcome in complex cases, this is something that I've been doing for quite a while now.
Wonderful. So we have a couple of questions already. Meanwhile, these are our Instagram handles, mine and Dr. Naisargi's.
Candidates to connect with us.
Yeah, if anyone wants to connect with us, feel free. If you want any opinion for any case, we are here to help. And now we shall swiftly proceed towards the questions. So yeah. Okay. So one very common question, I'm 40-year-old. Is braces and aligner useful for me?
I just answered this question 2 minutes back. That lady that you saw was a 44-year-old woman, and within a year, although it was a very simple case, yes, but we had to take a good time because the bone density was a little low, and within a year she has got this beautiful smile that you saw.
So age is not a bar, basically. It's just that the higher the age, slower results you get, but you get results. So we have 8-year-old kid who is having problem in teeth alignment. Can we initiate orthodontic treatment or wait for some time? Yeah, another common question.
Yes, this is also something that I just answered, that you may or may not need treatment, but you definitely need a consultation. So not all kids at the age of 8 years or 9 years need an orthodontic correction, but that is something that the orthodontist will guide you once you consult with them. So they'll see if there's something that needs to be corrected at that particular age, only then the child will be given treatment. Otherwise, if not, then we'll ask you to wait till the age of 12 or 13, or whenever, whatever suitable according to the patient.
Yes. Another question, younger patients are visiting us having concern about their looks while wearing braces. So how can we sensitize them?
So, although braces, I would say these days are very fashionable, because most kids in the school these days are wearing braces, and I've had patients who have come in who want those colorful, because if you go for braces, you can also put colorful bands around the braces. So they come in asking for themes. Like I want Iron Man themed braces, and I want Barbie themed braces. So one is that if the patient wants to go for braces alone, if they're not willing to go for aligners, then you can pitch it this way to the patient, that we can do it according to what's your favorite character. According to that theme, we can give you braces on your teeth and everything of that sort. Otherwise, of course, aligners is a very discreet option where the braces won't be visible. The movement will happen very discreetly, and nobody will be able to make out. Even if you and I are sitting this close, nobody will be able to make out if you have aligners on or not.
Very true. Now, one of the patients, he wants to undergo 3 treatments. Number 1 is root canal, another is molar extraction, and braces / aligners, basically orthodontic treatment. So what should be the sequence of treatment?
Yes. Now, I generally suggest getting all the treatments done prior to orthodontic treatment, because in the orthodontic correction, you are correcting the occlusion as well. So if you're going for a root canal, say, you will have a cap. Now the cap may interfere with your if you've gone for an orthodontic correction before getting a root canal, you'll have a cap on, and sometimes the cap may disturb your occlusion. Okay, so we'll first prefer going for root canal. We'll also prefer going for extraction, because that extraction, the molar extraction, the space could be sometimes, as I showed in this case, the video that we showed, the molar extraction was done prior to the treatment, and we could mesialize this second molar into that space. Sometimes you will not even need to replace a missing tooth.
Sounds perfect. Although I would like to add upon this, if at all there is implant planning. In this case, here the person has not asked, but if there is implant placed, what I have done in my practice is implant placement was done and orthodontic treatment was going on. The prosthetic part was done at last once the
Right.
orthodontic treatment was completed. So
Right.
implant placement can be done, but
Yeah.
orthodontic treatment can be done once the whole orthodontic setup has completed. Then only you give a proper occlusion over the implant. Only one molar was there, which for which I had done implant, and orthodontic treatment was going on. So, which type of foods are restricted while continuing with it? Braces, aligner treatment, and what recommendation you give to patients?
Yes. Now, aligners don't have any food restrictions because there's nothing sticking to your teeth, basically. So that is the benefit of aligners. With braces, you always restrict the patient from having anything that is hard or anything that is going to stick to the braces, because if something sticks, the patient will try to pull it out, and when they do, the braces may come along with it. Hard items would obviously get lodged near the bracket, and it may dislodge it. So yes, just hard and sticky food items, your pizzas and pani puris. And we generally also ask the patient to not bite anything from the front, because you always there's the forces are trying to pull the teeth in, whereas if you bite something from front,
Yeah.
the teeth may flare out. And of course, the braces also will get dislodged in the whole process. So you ask the patient to take small bites, put it at the back of the teeth, and chew it from there.
Now, what are the possible risk or complication that can happen during braces treatment overall?
Yes, now this is a very, very good question, that if you don't take the forces, the right forces into consideration, if the forces are less, movement may not happen at all. And if the forces are exceedingly high, it may cause hyalinization, which may stop tooth movement. That is still a simpler complication. A more grave consequence could be resorption. The roots may start to resorb and the tooth may become loose and will fall off. So this is why it is very important to always take a specialist into consideration whenever you're planning any kind of treatment, not just orthodontics, but any kind of treatments. When you're planning, you have to take a specialist into consideration, so that the right protocols can be followed and a good treatment can be given, because you should not end up with a problem which is more serious than your previous problem.
Yeah, very well said. I think interdisciplinary approach is the way to go in modern dentistry. Now, what is your recommendation for follow-up once the treatment is over? That is the another question.
Yes, I generally, once the retainers have been delivered, I call the patient in after 3 months, because that is when you can, it is halfway. The bone, the hardening of the bone is halfway. So you can see after 3 months if the patient has been wearing the retainers properly or not. You'll also, if in case the relapse would have started to happen around that time. If the patient has not been wearing the retainers properly, has not been following the doctor's instructions properly, relapse will start to happen around that time. So if at that point the patient comes in and you see that the patient has not followed your instructions, you can immediately take action and do something about it. But of course, most patients, once they're done with their treatment, they don't want to see the doctor anymore, because orthodontic treatments are anyway very long. So they've been coming to us for a year and a half, and then they,
Then they don't show up.
yes. So
They don't like
also
showing up.
follow up is very necessary. You, from your clinic, I think you can give a call to a patient, to the patient, that you have to come in for a follow up. Just a quick follow up, nothing big, and keep sending them messages over WhatsApp as reminders on wearing their retainers, and of course those small things that serve as motivation to the patient.
Right. Now, what is the ideal duration of this treatment? Like, does all patient get result within 18 months? Is it like?
Yeah. So as I said, you have to take multiple things into consideration. The age, the bone density. So the older the patient, the longer it will take to treat, because the bone will take time to remodel. Yes, but sometimes even patients of similar ages, say there's two patients, both of them of the same age, will take different duration, because of course the physiology is different in each patient. Also, the mode of treatment that you're going for will also have a lot of impact on the duration. If you're going for traditional braces, it may take much longer compared to your self-ligating braces. And if you're going for aligners, it will be even shorter. So, of course, those things are what will decide the outcome. And of course, the complexity is the primary. The more the complex case, the longer it will take to correct it. Yes. Okay. There's one more question. Once treatment is done, is there any need to do treatment again in future? No. If you have followed the doctor's instructions properly and you've worn your retainers, if the patient is, of course, coming in for the follow-up after 3 months, you do not need to get any kind of orthodontic correction again. That said, you also need to take certain things into consideration because most people these days have an impacted third molar coming in, and that can sometimes cause crowding in the lower arch, which is a very common thing that we've been seeing, that once the orthodontic correction has happened, because the erupting third molar, which is mesially impacted or in that direction, it causes crowding in the lower anterior teeth. So that is why we give the retainers, and around that age, we generally ask the patient to wear the retainers only during night time, so as to avoid these kind of issues.
Now, I think we have addressed maximum questions, but I would like to I'd like to allow you to give a closing quote. Like, what would be like one tip that you would give to each and every dentist who is practicing and who wants to, incorporate orthodontic practice in their dental clinic, of course, with a consultant, but how they should assess these cases and how they should, follow the protocol. Okay, at what age I should call my patient.
Right. So it's very simple. The patients, every time they're coming in, you have to see if there's any developing, because the sooner you address the problem, the quicker and the better for you as well as for the patient. So that is one golden rule, that if you see any developing issue, that is what you need to look out for. If there's any issue that is developing, you need to quickly address that.
Very well said. So, early interventions can be a game changer. It could reduce your treatment time, your treatment cost. It could drastically increase your comfort, and sometimes you might not need any treatment later on in life if you address them early. So, this was all about the amalgamation of occlusion and orthodontic treatment. And I would like to, know your experience regarding the same, Dr. Sandesh. And
Yeah. Yeah, thank you so much, Dr. Anshul and Dr. Nesargi, for that wonderful interaction that you both had. And as we are about to conclude our today's event, on behalf of Intas Pharmaceuticals and the Altis division of Intas, I extend my heartfelt gratitude to both of you for sharing your time and your clinical expertise and the clinical wisdom with us today. Your insights into the do's and don'ts of braces and clear aligners were not only informative, but also they were very much practical and adding a real value to our understanding and day-to-day practice. The clarity with which you both have addressed the common challenges and the complex issues and the decision-making pearls will surely help us to deliver better outcomes in, in terms of improved patient outcomes. Thank you once again for engaging and such an enriching session. I also extend my heartfelt gratitude to the marketing and sales colleagues of Altis division of Intas Pharmaceuticals, without whose efforts this event won't have been possible. So we are looking forward to more such events, more such sessions, interactive and enriching sessions. And till then, it's goodbye, and I wish you all a very good night and a very happy weekend. Thank you so much. Thanks a lot.
Thank you. Thank you, everyone. Thank you for having us.
Thanks, Doc. Fantastic session. Thank you so much.
Thank you.